Alright, g'day. We're going to go over ABG, Arterial Blood Gas Interpretation. ABGs are used to identify and monitor acid-base disturbances and to measure the partial pressure of arterial oxygen and also the partial pressure of arterial carbon dioxide. Assessment of the response to therapeutic interventions can also be mentioned with ABGs. For example, insulin in patients with DKA. Detection and quantification of the levels of abnormal hemoglobin can also be performed with an ABG. You'd be looking at things like carboxyhemoglobin or methemoglobin. Procurement of a blood sample. I just realised I've got a wet shirt. Procurement of a blood sample in an acute emergency setting where venous sampling is not feasible because you can actually get more results from an arterial sample. So there's 5 steps to interpreting an ABG result. The first is to evaluate the patient. The patient's symptoms and presentation will give you clues as to what the ABG is likely to show, and will also help you relate the results of the ABG to the clinical presentation. The next step is to assess the oxygenation. So if we look on the screen here, we'll see that the partial arterial pressure of oxygen should be greater than 75 millimeters of mercury on room air. This will then, obviously, relating to the value that you get on the result, will then inform you if the patient's hypoxemic or even if they're hyperoxemic as well. The next step is to determine the presence of hydrogen, or the pH. That should normally be between 7.35 and 7.45. If it is lower than 7.35, you'd be looking at a acidosis, and if it's higher than 7.55, you'd be looking at an alkalosis. In relation to that, you then want to determine the respiratory component. That's where you'd be looking for the presence, or sorry, the partial arterial pressure of carbon dioxide, which would normally be between 35 and 45 millimeters of mercury. In the context of it being greater than 45, you would be looking at a respiratory acidosis, or at least compensation for a metabolic acidosis. But if it's less than 35, you'd be looking at a respiratory alkalosis, or at least a respiratory compensation for a metabolic acidosis. Finally, you need to determine the metabolic component to the ABG as well. If the bicarbonate, or HCO3, is less than 22, that would be a metabolic acidosis with a renal compensation, or a renal compensation for a respiratory alkalosis. If the HCO3 is greater than 26, you'd be looking at a metabolic alkalosis, or a renal compensation for a respiratory acidosis. So we can have a quick look at a very kind of summary of that in a way, and a simple correlation of these figures. So a respiratory acidosis is identified with a low pH and a high carbon dioxide, while a respiratory alkalosis is identified with a high pH and a low carbon dioxide. A metabolic acidosis is identified with a low pH and low bicarbonate. Meanwhile, a metabolic alkalosis is a high pH and likewise a high bicarbonate. When you have compensation, you're going to see in a respiratory acidosis is a normal pH with high CO2, and a compensated metabolic acidosis again going to have a normal pH with low bicarbonate. Compensated respiratory alkalosis is going to have again a normal pH and low carbon dioxide, and a compensated metabolic alkalosis is going to have again a normal pH and a high bicarbonate. We can then use this information to tailor treatment as required. This can also be combined with other information like hemoglobin counts, white blood cell counts, lactate, and so on, to give you a clinical picture of what the presentation is. Let's just quickly discuss the contraindications for an arterial blood gas. you'd be looking at an abnormal modified Allen's test. Modified Allen's test is used to determine how well arterial blood supply is to the hand in the incidence of poor collateral circulation to the hand through the ulnar artery. You would be hesitant to use the radial artery to obtain a sample or insert an art line due to the risk of threatening that limb. Local infection or distorted anatomy at the site of insertion, which could be caused by previous surgical interventions, congenital or acquired malformations. You could have significant burns, for example, or trauma to that site. I was obviously going to rule out its use. Severe peripheral vascular disease is also another contraindication, as you're also again potentially threatening what already poor circulation exists in that limb. And similar to peripheral vascular disease, you have Raynaud's syndrome, which often affects limb diffusion. And that is arterial blood gas.